Okay, so hopefully we're live streaming. I have a bit of a cold tonight, so I'm going to really try and keep quiet. But welcome everybody to Cocktails and Canapes. Basically, we're just going to chat a load of stuff about EASD tonight. We have our special guests, as well as the DSN Forum team. We have Dr. Patrik Holmes, Alison and Rachna Selvan / we'll go with Selvan. Sorry, I had to tell you, I did warn you. Does everyone want to introduce themselves and just say a little bit about themselves? So my name's Amanda. I'm a diabetes specialist nurse from Medway in Kent.
I'm Beth. I'm a diabetes specialist nurse down in Southampton, but will be moving jobs shortly.
I'm Vicky. I'm a diabetes specialist nurse working with the Eden team at Leicester Diabetes Centre.
And I'm Tamsin, and I'm a diabetes specialist nurse at the Royal Stoke University Hospital.
Patrik?
Yeah, I'm a GP / GP with a special interest in diabetes based up in Darlington, one of the goggle docs as well.
Rachna?
I'm a pharmacist with a special interest in diabetes, and I'm based in Medway.
Me! Oh, poor Rachna. So just while people join the live stream, we just usually...
sorry, Alison.
See, I told you I'm ill. Alison,
you're not well, Amanda, don't worry.
The queen
no,
all DSNs in the whole entire world. Can we please introduce the lady that is Alison Cox?
Stop it now. I'm obviously Alison Cox. I'm a diabetes nurse and I have been for a while. I was at King's. I've just done a year in the community, but I've just gone back into secondary care and are now with the team at University College London Hospital.
Right, is there anybody else? No. Okay, I think we can get on. Okay, so for a little icebreaker while people are joining, we're going to talk about cocktails, I think. So favourite cocktail, Patrik?
Oh God, I didn't know that. Old fashioned.
What does that consist of?
So that's bourbon with Angostura bitters and a little bit of sugar syrup. Nice. It's dead easy.
Alison?
I'd have to go for mojito, which is rum, and it's better if you make it with dark rum rather than white rum, and then mint, soda, and a bit of sugar just to take the edge off. That's very nice, very refreshing.
Nice. Rachna, do you have a favourite?
Do you know what? I was just looking up what's actually in my favourite cocktail because I have absolutely no idea.
Tell us what it is. We might be able to help.
Oh, it's a porn star martini, my favourite.
It's basically passion
fruit.
Yeah, and prosecco or champagne, that kind of thing, isn't it?
Yes, it's got a spirit in it. I'm not sure which one though.
Martini, maybe.
Martini. Yeah.
Let's go with that. Hello, Vicky.
So mine has to be lychee martini. I think it was that I had for the first time in London whilst out with the goggle docs.
Yes. Sorry, who's next?
I'll take it, shall I? I think mine would be a pina colada. I do like a little bit of exotic feeling.
That was mine. Mine.
Sorry.
It's all right, I'll let you have it. Besties.
Yeah.
Tamsin?
Mine would be an espresso martini.
No, I don't like
I had a lot of stuff when we went out in London. I had about 6.
But I don't drink alcohol anyway, so I don't have one.
She says from
as our faces all go shocked.
Live from my bar in my garden. Okay, so I think that's probably all the people that are going to join us. Welcome everyone on Facebook. If you have got any questions about any of the stuff that was at EASD, well, we're going to start talking about some of the new new trials and things that came out. If you've got any questions, please put them on the Facebook group chat thing, and we will ask them live to our special guests. Okay, so I think we're probably going to start with Beth, because Beth's going to leave for another meeting. So I think Beth wanted to talk all about HeartDoc. So Beth, tell us all about it.
Yeah, so HeartDoc, it was saved right to the very last day. I was excited about it all week. I cannot remember for the life of me what all the letters stand for, because they seem to come out with more and more random ways to call studies, don't they? But it was looking at people with fear of hyperglycemia. So people that are very scared of having high blood sugars, so they run their sugars really, really low, and what sort of things we can do to help these people. And I definitely have a fair few of those. So they were looking at kind of the reasons behind why people might do this, you know, whether it's they're petrified of complications. And I've definitely got, you know, a patient that I know that he's similar. He's got family that's run into complications, and so he's terrified of that, and he kind of runs his sugars low all the time. He won't use technology, you know, because they're constantly he can see his figures if he's using tech and stuff. So they were looking at these similar sorts of groups and how they could help them. So I think, I'm pretty sure it was King's, wasn't it, Alison? It was Patrik and the gang up there, Helen Rogers, and, you know, the amazing team. And they put it together a program for these people, so kind of like an education program. And they did say that one does already exist, but there were certain differences. So the HeartDoc program was slightly longer. It had some psychology input as well as DSN input. So I think they had 6 sessions in the HeartDoc versus slightly less in the other one, which is called BGAT, which people might have heard of. So similar thing. I mean, I think the findings were kind of what we would expect. So by sending the people to education, they did have much better outcomes in their distress scores and all of those kinds of things. And their depression and anxiety did lift. They did have reduced hypoglycemia. But quite interestingly, the end kind of the follow-up results. So the HeartDoc program did show that 24 months follow-up, I think it was, might have been 12, but they had much the levels of their diabetes distress and depression scores and things still remained low, whereas the BGAT one went back a lot higher. So the other thing that was quite interesting is all of the participants were offered some form of technology, whether that be a pump or CGM. And so I think the numbers, they were quite high. So I think most of them did take up some form of CGM or a pump, but actually, again, as we've seen before, it showed that education is key and it's not the technology. So I think a lot of them found that, you know, they came away from the technology and it was actually the education, the time spent with the psychologist and the DSN and learning about hypoglycemia and kind of reversing those behaviours maybe, or the things that they're scared of and things. So it was a really interesting study. Lots more came up, you know, for the future. So would it be cost effective long term? Is it something that we can run, you know, more widespread rather than referring into a specialist kind of service like King's, for example? Would it work in sort of real practice, you know, like in our normal teams? And also, is there a way that we can sort of look at the people that would be high risk for that kind of thing? So fear of severe hyperglycemia, sorry. And so is there a way that we can look at the at-risk groups and maybe do some more work with those kinds of people? But I thought the education thing was quite interesting. I know, Alison, you're a big thought on this, haven't you?
Yeah, so HeartDoc, which is a hyper awareness restoration program.
Oh, there you go.
You go, just trips off the tongue, doesn't it?
It does.
Yeah, so this was an extension of previous research programs that had been done, mainly coming from Stephanie O'Meara and Patrik Chowdhury at King's, but it was an international study and there was many centres around Sheffield, etc., and those in America and the continent. And one of the main sort of take home point was that you had BGAT, which was an established program for blood glucose awareness training, but then you had HeartDoc that brought in more psychology. And they did a lot of things that are sort of being transferred into Daphne now, the psychology support and follow up, looking at people. They talked about people who, you had your EMU, so the person who buried their head in the sand and ignored the fact that the blood glucose was going low. You had your soldier or your sergeant major who sort of marched on through, and it was getting people to sort of identify with which group they were, and then tailoring the sort of advice, etc., the support for the individual. And I think that's the key message for for all diabetes really, is that we have to remember the individuals here, and it's we have to tailor our education, our advice, our technology to the individual to make sure it suits them. One hat, whatever the expression is, doesn't fit all, and I think that's one of the key things. Like you said, Beth, education was paramount, or support, or the psychology input that they got, not just the technology. Interestingly, I think off the top of my head that like 90% of the participants had been offered or had some sort of technology in the past, but actually at the beginning there were quite low numbers of people actually using things like pumps and sensors. That increased as they went through, and they got better support and they were able to interpret it. And I think that's another little take-home message for us, that you can't just throw technology at people. They have to have some education. And then we get into the slightly contentious area where some people withhold it if they haven't had education. I think again it's about tailoring that education and that support to the individual.
Yeah, that's definitely a controversial point at the moment, isn't it, about should we be not making or forcing, that's maybe not the right word, but should we be ensuring that patients have had some form of education before they start to use technology? And
I mean the previous study, the Repose study, which was done comparing people who were going into structured education, and again they used the standard Daphne for this, and they were separated into two groups: those that remained on MDI and used the expert meter to help them with their dose calculations, and those that were put onto pumps. Both groups showed really good reductions in HbA1c and severe hyperglycemia. However, there was no difference between the two groups. So again, that kind of backs up the theory that just giving somebody with a raised HbA1c, or somebody who's struggling, or whatever parameter you use, technology is not the answer. You need to either match that technology if it's appropriate with the education, or start with education support, or identifying what their issue is, what their barrier is to improving their diabetes, or their journey with their diabetes. I'm avoiding saying control here, if you notice, but it's about improving their life, with their quality of life with diabetes.
I think it sometimes stems back from, because I think hypos are seen as a normal thing in diabetes, aren't they, in a sense? And I think for some people, when they become a hypo unaware, they don't see that actually as a complication of diabetes. They just see it as kind of normal. And we have a number of patients, like Beth has said, that have this problem, and they're on pumps with CGM, but they're still suffering hypos, because it's almost like that is kind of normal in a sense, so they don't feel like it's a problem, and that we can't quite work out where that stems from for some people, because they're very scared of being high. That is part of it, obviously, but they can't seem to grasp that actually this is almost as much of a problem as them running high, because if they're collapsing and suffering head injuries and things like that, which some of our patients have had, but they still don't seem to get that actually is a complication of diabetes. And I think that it does stem a little bit from actually how they were taught, maybe when they were diagnosed, about hypos are a normal thing, and actually you accept them, and not that really we should try to avoid hypos as well as avoiding highs.
I think that's key. We've all got experiences of people saying, oh, I remember the first thing I was told was that my blood glucose level had to be between 4 and 7, and it's probably the first thing they were told, and they maybe wasn't explained properly, and that sticks with them. So then they run their blood sugars there, and they just, as you said, they accept collapsing they accept not being aware of hypos, because their purpose, what they're looking for is to maintain that blood glucose levels. And then you've got people frightened of being high. You've also got, we have got the other way as well, people are frightened of being low. But it is, I think sometimes the message, or the mismessage, if you like, started early, and that takes a very long time to unpick and find out how we can support them.
Yeah, I was just going to say, Alison, is it the way that we deliver that information when someone's first diagnosed? Do we put too much emphasis on hyperglycemia and not enough emphasis on the complications of hypoglycemia as healthcare professionals?
I think we possibly do. There's so much you have to tell. You sit down with the person newly diagnosed with type 1 diabetes, and your head's exploding with everything you've got to tell them, and they will only pick up on certain things. And I can guarantee one of the questions they will ask is, apart from did I cause this, which is often one of the things they think, is what should my blood sugar be? And we rattle off 4 to 7, 5 to 8, whatever. Should we sort of say, well, this is what your blood sugar is now. This is what we would aim to be. However, you will have times when it's lower than that, and then you run through that. And you will have times when it's higher than that, and you run through that. And trying to sort of normalize the range whilst emphasizing the danger points. So yeah, I think sometimes it's not deliberate, obviously, but sometimes our message isn't clear, and unfortunately people will focus on one fact.
Well, I think that kind of links in really nicely with the type 1 consensus document that came out at EASD, EASD sort of thing, wasn't it? I'm trying not to speak too much here, but I think Tamsin knows all about it. And also there's dual pumps was another thing that was there, with the glucagon and insulin in the same pump. So I think maybe that's, do you want to explain, Tamsin, before I die?
Yeah, so I mean, first off, obviously the consensus is, is something that we've all been kind of waiting for since ADA mentioned it previously, and it's a document for people with type 1 diabetes and the future. So I mean, it starts right from diagnosis and kind of the challenges of differentiating between the types of diabetes. But it goes right through to treatment goals, talks about pregnancy, managing hypos, as we've talked about, insulin therapy, glucose monitoring. So it's a really, really detailed document. It's I think they said it's 37 pages, so it doesn't really seem huge, but obviously they've packed like a huge amount of information into this one document. Talks about SGLT2s, talks about future treatments, and so a really interesting document for people who want to have a read really about the guidance and with regards to sort of managing people with type 1 diabetes right through from diagnosis to everything else. And part of that on the EASD was talking about technology and looking at the dual therapy pumps, which I watched a couple of the presentations around this, and kind of had a pros and cons. I think I'm not completely sold, I don't think personally, on it, mainly because I think the hybrid closed loop systems have shown such excellent results recently. So and I think that some of the side effects from the second therapy, which can be glucagon, some people do suffer from sickness from it. So I think, personally, I know I suffer really severe sickness from glucagon, so I think that's why I'm not particularly sold on it at the minute. But I don't know whether it's because if it's drip fed, are you going to get less symptoms from a smaller dose than you would do from a whacking great big IM dose that they give you. So actually, would it suit these people that maybe do have hypo unawareness and that are on pumps, are still suffering hypos on CGM, with the CGM hybrid closed loop systems? Is it these people that it would be really, suitable for? But I suppose it is just the side effects that kind of put me off a little bit, in the sense of, does it, are they going to be able to try and mitigate those side effects a little bit, really?
Is there anything you wanted to add about that, Vicky or Alison?
I was just going to add to what Tamsin said. I think we all know that, when we give glucagon in an emergency situation, people invariably are quite sick after it. So there must be some effect, but it's probably lessened by the fact, as you said, it's drip fed in. There also, I'll put my hands up. I have got no clinical experience of these dual pumps. Obviously, I'm not sure anybody has really, and I've only read in a couple of papers, but I know that it does reduce hypos, especially after exercise. I think is more significant, and I suspect if they do come in, it's going to be for, at the moment anyway, it's going to be for quite a specific clinical group of people that perhaps do have very severe hypoglycemia, and this may work. The other one is that they're also using pramelin. I'm going to have to read it out. Pramelintide, which is an amylin, which is, again, I think there's one or two papers showing that does again help with time in range. Going back to the glucagon one, the other downside that they noticed was that there was increased periods of hyperglycemia, possibly as the glucagon pushed the blood sugars back up.
Yeah, I think all those trials are in America. I don't think we've got, especially that whatever it was called,
Pramelintide.
Pramelintide. Yeah, that's not available in the UK.
No, I didn't think it was
available in the States for years, hasn't it?
Yeah, it's.
Was there some sickness with that one as well, or was there nothing with that one?
I don't think there was. That was mainly weight gain. Patrik will know better here than me, but it just it reduced weight because it makes people feel fuller for longer. Is a very simple way of putting it. So wasn't nausea like you would get with an SGLT2. A GLP-1. But there was potential, because it acts on the gut, that there will be some GI side effects, I would imagine.
Yeah, I think my understanding is it's produced by, I think, the beta cells as well. Yeah. And it mainly positively impacts on weight. So and it has a glucose lowering effect itself, but it's mainly, as you said, by modifying sort of eating, really, which is so a little bit like a GLP-1, I suppose, in that, except it's from a completely different
route. Yeah.
Speaking of GLP-1s,
just before you go,
okay.
Geraldine from the Diabetes Technology Network has very kindly commented on Facebook to say, good for exercise and history of severe hypos and hypo-unawareness. So thank you, Geraldine.
Okay, so we'll move on to type 2 now. So there's some really great stuff that Vicky and Patrik were going to talk about. So Surpass 2, 3, 4.
Yeah, I'll start with Surpass 2, if that's okay. So this was presented by Professor Melanie Davis, and this was looking at the efficacy and safety of tirzepatide, which is the dual GIP GLP-1 agonist versus subcutaneous semaglutide. So the primary objective was to demonstrate that tirzepatide 10 and or the 15 milligram once weekly doses were not inferior to semaglutide for mean change in HbA1c at 40 weeks. So I just went through some of the results. So there were 4 arms to the study. 5 milligrams of tirzepatide, 10 milligrams, which was titrated up in 4 dose titration steps, 15 milligrams of tirzepatide titrated in 6 dose steps, and 1 milligram Formin. And the results showed that the mean HbA1c reduction for tirzepatide was better than semaglutide. So for an HbA1c of those achieving an HbA1c of 7% or equal to or less, 81% achieved that in the semaglutide group, 85% in the 5 milligram tirzepatide group, 89% in the 10 milligram tirzepatide group, and 92% in the 15 milligram group. And then coming on to the body weight, again, the tirzepatide had greater body weight reduction as well. The 15 milligrams, it was about a 13.1% reduction in body weight, which equated to a mean of 12.4 kilograms versus 6.7% and 6.2 kilograms for the semaglutide group. The sort of side effects, mild to moderate nausea and diarrhea, were quite similar across all groups. And it had shown that there were superior and clinical meaningful improvements in glycemic management and also significant reduction in body weight with a low risk of hypoglycemia. And I think Patrik can probably elaborate on some of that with some of the other SURPASS studies, but I was quite amazed at sort of what it had achieved, really.
Can I just clarify, was that the 1 milligram semaglutide, or was that?
Yeah, 1 milligram, yeah.
So I think one of the, absolutely, I mean, so this is the newest thing from Lilly, and I think it's likely to be launched next year. So it's likely to be launched without its cardiovascular outcomes study. So it's different from a lot of the newer agents we've come across. So it's sort of going backwards in a sense a little bit on these surrogates, but very impressive numbers. The one thing which stood out for me, because actually the SUSTAIN-2 was first data came out at the ADA, and one of the controversies within that, bearing in mind it's against semaglutide, and it was a short study, but there was excess deaths in the tirzepatide arms. There were 3 deaths at each dose, 5, 10, 15, and there was only 1 death, I think, in the, and they're all similar sized groups, in the semaglutide group. But the excess deaths, there's been quite a lot of discussion about that, and they were all COVID related, because obviously these studies were done during COVID. But even so, it's that imbalance gave me a little bit of concern, because it's up against a drug which is arguably as effective as any at lowering, MACE, that major adverse cardiovascular event, heart attacks, strokes, fatal or non-fatal. So which leads on to, for me, why SURPASS-4. I'll come back to SURPASS-3 in due course, but SURPASS-4. So this was, SURPASS was, it's high cardiovascular risk patients. So most of them had already had some sort of cardiovascular event, and they were either started on insulin glargine as a basal, or they were given tirzepatide, again at the 5, 10, 15 milligram dose. And I suppose, and it was a relatively short study, 52 weeks. All of these are all open labels, so there are issues about that, but it's very difficult not to do it that way. So and the outcome of that study was very similar to the others, in a sense that there was this dramatic reduction in HbA1c and weight. I think in that study, you're looking about, at the 15 milligram dose, you're looking at 2/3 were achieving 10% weight loss, and about 1/3 achieving 15% weight loss. You're getting HbA1cs well in excess of 20, 24, 25 millimole reduction. So we're talking class leading efficacy both in HbA1c and weight. But I suppose, why was I bothered about that particular study? It was a high cardiovascular risk. What happened to the deaths? Were they higher? And they were much lower in the tirzepatide dose group. So and a nod to the cardiovascular outcome study, which is going on, quite brave really of Lilly, because they've got tirzepatide against gelaglutide, so Trulicity. So it's so what more about it? So there were a couple of other studies, sub-studies, which were shown, and this is from SURPASS-3. So two groups of people from SURPASS-3 were investigated more intensely. One group was looked at with MRI to see what was happening with fat, and the outcome of that essentially were they were losing a lot of liver fat. We were seeing improvements in terms of their ALT and AST, and they were losing abdominal fat, half visceral, half subcutaneous. So basically, they were, on the whole, you were losing fat where you wanted it, and it particularly you can see this potentially being a treatment because of the presumably, well, they reckon the weight loss was only part of the beneficial effects on liver, but you know, you can see it as a treatment for NAFLD or obesity there. And then there was a CGM study which, surprise, surprise, it basically worked. Time within range was a lot better. So that was that. And then there was a nod. So we just, whilst you're getting your head around tirzepatide and what that is, this GLP-1 agonist, dual agonist, there was the latest, the absolutely latest molecule coming from Lilly, which was tagged as triple G, and this is a triple agonist. So this is not only GIP and GLP-1, you're adding glucagon, and at least in a mouse study. So we're a little bit early on this one, but in mice, the triple G was better than tirzepatide. So I suppose all of this sort of nods to huge changes in terms of managing type 2 diabetes, and I would say obesity as well, and other complications of type 2 diabetes like NAFLD going forwards, using these gut hormones, which, you know, a lot of the knowledge of this, as in terms of clinical knowledge, has actually come from bariatric surgery. So, you know, the surgeons for once have actually left us something. They haven't chucked everything in the bin. So
wow. Sounds really good. Was there anything else that anyone found really interesting that you wanted to bring up?
Can I get one in?
Yeah.
I mean, there's a whole load I could rabbit on about, but there was one which I found really interesting, was so it was some early preliminary data from the Retune study. So the Retune study is from the same people who gave us the direct study. Okay, so not far from me, actually, just up in Roy Taylor and his band up north in Newcastle. It's even north for me, and they talk funny up there. But they looked here at people with obese. So they had a top BMI of 27, and they got them. They were definitely type 2 diabetes, and they got them to lose 10 to 15 kilograms. So yeah, and they achieved it. And those people who did get that 10 to 15 kilogram got the identical benefits that we saw in direct. So essentially, for me, this says we should be defining obesity not on BMI, but on complications. So if you've got type 2 diabetes, whatever your BMI is, there's a large component of it's going to be related to ectopic fat in the wrong place. And some people are able to store a lot of fat subcutaneously, others can't, and they rapidly start storing it around internal organs. Remember that dual theory of dual fat cycle of theory of type 2 diabetes that Roy Taylor sort of came up many years ago now, but it was all about, you know, once you've filled up your fat reserves, it then goes into your liver, then the liver through triglycerides then starts laying down fat in your pancreas, and small amounts in pancreas then leads to dysfunction in that pancreas. And obviously the liver fat is part of the insulin resistance story. So if you can lose a little bit of fat from your pancreas as well as your liver, Bob's your uncle, you're in remission from type 2 diabetes.
I think everyone watching now is going to go and get on the scales and going to go on a diet.
Can I just ask a quick question for Patrik? Given what you've just said, do you, at the moment, you know, if we go according to guidelines and everybody's got slightly different ones, we're not starting GLP-1s until BMIs are at certain levels, which, you know, you're smiling already. we, you know, as specialists, we might make the decision that somebody's already on 4 agents, etc. They've got complications. We're going to start it earlier. Do you think the guidelines will reflect this eventually, or sooner rather than later? When do you think it might come through?
Well, I don't know. So, I mean, the problem with this is the cost of some of these new molecules, isn't it? So, I mean, you know, SGL, if you look at the draft NICE guidance, which is out there, which for type 2 diabetes, they've completely gone for SGLT2 inhibitors, you know, in a way which I think is actually beyond the evidence base, because they've gone with modeling. But you know, they're suggesting we should consider SGLT2 inhibitor regardless of their HbA1c if they've got a 10-year Q risk of 10% or more. So that's what they've done with SGLT2 inhibitors. But GLP-1 seems to be stuck sort of, you know, 10 years ago, where we're still meant to. So I mean, the feedback for NICE is actually very soon. I'm just hoping we're going to have some sort of revision that like we did. But I mean, I think the evidence base for BMI cutoffs is pretty poor. So the way I look at NICE guidance is actually how NICE tell us these are guidelines, not tramlines. So they should guide clinical practice, but that's all. Ultimately, it comes down to a healthcare professional's judgment, which, you know, is more valuable than anything else, I would say, because that's captured a lot of the personal details. So I know that's probably, and I'm a CCG lead, so I think we should be managing patients to the best of our ability, rather than necessarily always looking at the bill. The bill, we all know, is in complications. And if you want to save not just your budget, but the planet, because the best way to actually to have a negative carbon impact on the management of diabetes is not fussing about all these expensive agents and insulins or technology or blah, 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 blah. It's about preventing complications. If you do that, that's when you have the positive impact on people, you know, budgets and even the environment. So
I think that's the problem with NICE guidelines, though, isn't it? Is that people who are non-specialists will want to follow them to the letter, and they just need to be up to date, don't they? They need to be up to date. So we, as the DSN Forum, are submitting our stakeholder into their draft, which finishes on Thursday. So you've still got a couple of days. If anyone else wants to submit any comments to the draft type 2 guidelines, you've still got a tiny bit of time. Really big form, a tiny bit of time. You might be able to do it. And last but not least, I'm going to move on to Rachna. So Rachna, I've been a little bit unfair with Rachna. Rachna is my lovely PCN pharmacist. She's with me. We're setting up one of the first DIAS teams in the country. So if you haven't seen that, have a look at Diabetes in Primary Care Network's document. It's about a 60-page document, very nice if you're trying to go to sleep at night. And that's what us two are doing. But this was Rachna's first ever EASD. So what kind of things do you think newbies can get from EASD, Rachna? What did you find useful?
You know, because I come from primary care, I feel like we're quite sort of historically governed by what the CCG tell us to do, or, you know, what reps try and sway us to do, and sort of things like that. So what I found most helpful was the fact that EASD is so evidence-based. There was a lot to take away from the conference in general, but they sort of advertise their e-learning portal, and that was brilliant. It's got loads of sort of modules, and as Patrik was saying about, you know, the focus on cardiovascular health being one of the most significant and challenging aspects of both type 1 and type 2, they've got really good sort of modules on that. And, you know, they're not small. There's like 7 modules for just cardiovascular health alone, so it's sort of really comprehensive and really important. So if any of you have got sort of areas that you want further education on or anything like that, that's a great place to start. And actually they've got some really good evidence and of management of non-alcoholic fatty liver disease, which isn't a sort of an expertise area of mine, so that's something I'm really looking forward to doing. And yeah, just loads of other stuff like that. They are doing patient casebook podcasts as well. So I feel like seeing that in real life and how it's actually working for their patients when they are so evidence based is going to be really valuable.
Yeah. And it's all free. I mean, you don't have to be a member, you just register and you can use it for free. You don't have to have like a login or, you know, you'd have to just register it and then it's free. And I think the RCGP have actually accredited some of the modules, so that's really good. If you need it for yeah, Patrick.
Seven
modules.
But as already been said, it's you don't have to go through the RCGP. You can just go straight to EASD learning, and it's actually run by a Scottish woman who sort of run it. So it's really good stuff. My conflict of interest there is, in a sense, I was involved in negotiating on behalf of EASD learning with the RCGP, so to get a credit, but they're going big and there's a lot of content coming. And I think since most people are managed in primary care, I think it's a real opportunity for us to learn from experts in terms of upskilling. But yeah, it's good.
So don't be scared, register, do some modules, great CPD. Right, I think that just about wraps it up, unless anybody's got any further questions from Facebook or any questions or any further things to add from our lovely speakers.
No, nothing on Facebook.
The only thing for me, there was a couple of nods to, I know you because Amanda, I can talk until the cows come home. In fact, they've already gone to sleep by the time I finish. But there was also some stuff about what next after metformin, which I thought was interesting. So there was one study, which was an American study called the GRADE study, which we heard a bit about at the ADA, but they've finished their data now. So they've not published yet, but they, and what they did in this study, it was people were on metformin and then they were either offered an SU, which was glimepiride, a GLP-1, which was liraglutide, or a DPP-4 inhibitor, sitagliptin, or a basal insulin glargine. But no SGLT2 inhibitor was in that because they said it was too soon after the introduction of that drug class, and there's no pioglitazone or rosiglitazone for that matter, even though it was a US study and both those drugs are available in the States, because it was just soon after rosiglitazone had its problems. So anyway, so what was the output of that? They looked at outcomes in terms of glycemia. Liraglutide and basal insulin did best in that. And really DPP-4 inhibitors, if you had a baseline above something like 75, was hopeless. And they rapidly needed to go on. They looked at microvascular complications. There was no difference between any of them. But possibly the most interesting was macrovascular complications. So this wasn't a secondary, wasn't like these cardiovascular outcome studies where everybody, to go into it, you have to be at least very high risk. These were people, bog standard type 2 diabetes, average 4 years of type 2 diabetes. But what they showed in that study, if we looked at overall cardiovascular disease, including heart failure, then you actually saw benefits with liraglutide compared to all 3 other groups. So that was interesting. And then there was a UK study called the TriMaster, which is a bit of a complicated design, but basically they used a crossover design. So individual patients were tried on 3 different treatments and they measured the HbA1c. So this was just based on HbA1c. And it was towards, they were looking towards sort of a personalized medicine. So they were looking at 2 things really. One was, you know, what was best for HbA1c, and they sort of subdivided. They thought that people with a BMI above 30 would do better on a TZD to pioglitazone compared to a DPP-4 inhibitor, which was sort of weight neutral. And then they looked at people with different levels of kidney function. And if their EGFR was above 90, it was the group which was between 60 and 90, and they were so it was either above 90 compared to 60 and 90, and they got SGLT2 and DPP-4 inhibitors. Anyway, the top monitor in terms of glucose control, if you've got a BMI above 30, a TZD was better at lowering glucose, as they predicted, compared to a DPP4. And again, if you've got an EGFR above 90, SGLT2 inhibitors win, where if it's below 90, actually DPP4 inhibitors win in terms of glucose lowering. But there are tiny differences between them. But the thing which actually got me most interested was actually in terms of which agents did patients like best, or which ones were the most likely to continue with. And it was the one, it was quite straightforward. It's the one which caused least side effects, but there wasn't one class which had more side effects. So in a sense, it's a nod towards, we almost should basically just give them a bunch of pills and say, try these for a bit. And then once you've tried those, try another, to try to work out which one, because one of the biggest challenges for me is actually getting people who don't think they're ill in the first place and just wonder why I keep on fussing them about this HbA1c business and telling them, you know, bad things may happen if they don't look after themselves and they need to lose a bit of weight, etc. But, you know, for them to take pills. So the top model of it is overall, if you can somehow prescribe a liraglutide or a GLP-1, probably that's the best, but whatever, the punters have got to be able to take the medication which comes in throughout all of it. So, and there's a lot more of this precision medicine going through.
Wow. All of us are like, how do you keep all that information in your head? You're probably not even reading that, are you? That's like totally from memory. We're all in like amazement here. But I think we've run out of questions. I know I just wanted to say about the influencer poll, because Patrik was always going to be top of EASD influencers, but I managed to get to like 4 or 5 at the high time. So yeah, and it only took me 1 million tweets.
But you were just stealing my ploy, which is just to tweet the hell out of the EASD, and it works. It did work. I got very high up there. And I was just going to say also that TriMaster sounds a little bit like a ThighMaster, and I just can't think about it's like exercise machine or something. Where do they come up with these names? I don't know. So any more questions, guys, before we say goodbye? No, nothing on Facebook. Fantastic.
No.
Well, I think do we have a date for our next one? I think the next one we're going to be speaking to DPC.
23rd of October, 10 a.m. I think.
There you go. So that's going to be a brunch style rather than a cocktails and canapes. And we're going to be speaking to Toby and Maggie from DPC. And they're going to be telling us all about the fantastic program that they've got, their actual first live conference in how long? 2 years? 2 years, yeah. So we're all very excited about that. And I'm sure there will be lots of updates from that DPC conference as well. So without further ado, I think we're all going to say goodbye and good night. And yeah, bye everyone.
Bye.
Bye.